The second presentation will be entitled Advanced Analysis of pH Impedance Studies for GERD Diagnosis, and it will be presented by Dr. Eduardo Savarino from Padova, Italy, and by Dr. Nicola Di Bartoli from Pisa. Dr. Savarino is Associate Professor of Gastroenterology at the University of Padova, and Dr. Nicola Di Bartoli is Associate Professor of Gastroenterology at the University of Pisa. Both are interested in gastroesophageal reflux disease and motility disorders.
Dear colleague, welcome and thank you for the opportunity to present today about the Lyon classification and the use of advanced analysis of pH impedance studies for GERD diagnosis. As you know, during time, different attempts to better define patients with esophageal symptoms, in particular those who are suspected to have GERD, have been done. This is a cartoon which depicts the evolution of the main landmarks in GERD assessment until the Lyon consensus that was published in 2018 and was the main topic, is the main topic of our discussion today. In the Lyon consensus, we evaluated, summarized, and criticized the previous guidelines and, of course, the current evidence on the role of clinical history and questionnaire in the GERD diagnosis, the role of PPI trial, the role of endoscopy, histology, and, of course, the role of ambulatory reflux monitoring, with particular focus on the interpretation of pH impedance monitoring, reflux symptom association, and novel metrics introduced in the last year to better diagnose GERD and to help the clinician to make a more objective diagnosis of gastroesophageal reflux disease. Also, we introduce the role of esophageal air resolution manometry in the GERD context. Going back to the use of impedance pH reflux testing, the rationale behind their use is determined by the fact that in the last 20 here we highlighted as PPI trial has shown limited ability to identify patients with GERD as compared to more objective standardized tests. The endoscopy has demonstrated poor sensitivity in diagnosing GERD since the majority of the patients have no lesion at upper endoscopy, particularly if they are tested after PPI trial or during PPI trial. Also, 24-hour pH monitoring only has shown suboptimal sensitivity for GERD because of the day-to-day variability, because symptoms reports have limited reliability during the testing day, and symptom association probability and symptom index are suboptimal indexes to correlate symptoms to reflux episodes, to reflux events. On the other hand, pH impedance testing has been considered and recognized by many experts as the gold standard for the detection of reflux episode, with some additional advantages, including the ability of detecting the gas movement along the esophagus and the opportunity to test patients also on PPI therapy. This, of course, helps in improving our ability to correlate symptoms to reflux episodes because of the ability of detecting also non-acid reflux episodes. This immediately increase definitely the our yield of symptom association to 67 to 77%, as demonstrated by this study from Bredenord published in 2006. This study was replicated by several other studies published later on from different centers around the world, highlighting that the ability of impedance pH testing in patient study of PPA therapy in increasing our diagnostic hill increase of about 10 to 20%. An additional benefit of impedance-based testing relies in the opportunity to narrowing down the proportion of patients with functional harbor uh, thanks to opportunity and ability of identifying patients with non-acid reflux disease. Again, this helps to better identify patients with non-erosive reflux disease and symptoms related to reflux episodes and better identify patients with reflux hypersensitivity, again of about 10%. From an outcome perspective, this meant that we were able to better stratify our patients and to better identify those who were more suitable to therapies like antidepressant or SSRI, and better to identify those who have a better response not only to medical therapy but also to anti-reflux surgery. In this study from the St. Louis group, uh, the researcher identified has symptom association probability to all kind of reflux and also the distal mean nocturnal baseline impedance, a marker of mucosal integrity of the esophagus, were the best predictor of response to medical therapy and also to surgical therapy. An important step forward in the evaluation of the role of impedance pH testing was done by this randomized control trial published on the New England Journal of Medicine in 2019, where a researcher for a VA cooperative hospital in the United States performed a randomized trial and collect a large sample of patients with esophageal symptoms who underwent impedance pH testing. After a deep analysis and excluding those patients who responded to PPI therapy or who had different diagnoses as compared to gastroesophageal reflux disease, they identified 78 patients with reflux-related PPI refractory harbor who had a positive symptom association probability and or a positive an abnormal acid reflux. These patients were randomized to surgery, active medical treatment, or control medical treatment, in other terms, placebo. And they found that this stratification obtained with impedance pH testing was able to better identify those patients who are responder to surgically as compared, of course, to active medical treatment, PPI and antidepressant and baclofen, or placebo. This, of course, is a landmark study because provided the evidence and the strength that impedance pH testing is able to stratify patients who are refractory to PPA, to medical treatment, and of course, provided evidence that surgical option therapeutic approach in this patient can be feasible and can be recommended. Another advantage of impedance pH testing was is the ability of detecting not only the non-acid reflux disease, but also the gas movement and therefore understanding if there is a behavioral disorder underlying the symptoms of our patients. This study was published this year, the end of last year, not real press now, but it will be published soon on CGH, and underline has patients with a reflux hypersensitivity as compared to those with functional harbor and non-erosive reflux disease have more frequently a behavior disorder like supragastric belching or rumination, suggesting, of course, that this patient should be treated differently from those who are treated for gastroesophageal reflux disease with PPI, with medical therapy, or with surgery. Another important issue that was highlighted by this study with impedance pH testing is the possibility of identify those patients who report or who have more frequently supragastric belching or gastric belching and correct this behavioral disorder with cognitive behavior therapy. In this study published 2 years ago by the London group of Daniel Sifrim, we see how patients who underwent CBT after 3 months had a better quality of life and a marked reduce of supragastric belching in the analysis of impedance pH testing. The drawback, of course, of this study is that the analysis has to be done manually, and the tracing have to be read with particularly careful and attention to identify with a good eye from the researcher patient who have an increased supragastric belching during the testing day. Another major advantage of the use of impedance pH testing relies in the opportunity to test patient off on PPI therapy. A lot of debate there was in the last year on when and which patient test in the two different modalities. In the Lyon consensus and also before in another consensus paper that was published on neurogastroenterology motility in 2017, we concluded that patients who have evidence of gastroesophageal reflux disease and endoscopy or prior pH testing should be tested on PPI therapy, whereas patients who had lack of evidence of gastroesophageal reflux disease at the endoscopy or who have atypical symptoms or underwent anti-reflux surgery or have recurrent or persistent symptoms on PPI therapy should be tested off PPI therapy. Of course, testing off on PPI therapy means that patients have more non-acid reflux episodes, and this increases our ability to correlate symptoms to non-acid reflux episodes. In these terms, the additional yield of impedance pH testing over pH testing only can rise to 20 to 40%. The result of doing an pH impedance testing of medication on medication is that we are able to better stratify our patient and categorize them as patients affected by GERD, gastroesophageal reflux disease, mainly non-erosive reflux disease, or reflux hypersensitivity, or no GERD, which means functional symptoms, or an alternate diagnosis like rumination, supragastric belching, or eosinophilic esophagitis. Of course, there are not only advantage of doing impedance pH testing, there are also some drawbacks, mainly related on the technique and similar to catheter-based or wireless pH metry. Impedance pH testing is impaired by day-to-day variability, lack or delay in symptom recording during the testing day, and the well-known suboptimal ability of correlated symptoms to reflux thanks to SIP or SI. Specific of pH impedance testing, there is the need of manual analysis of impedance pH tracings. That means that the technique is time consuming, and also there are some limitations related to the limited standardization of reflux episodes and novel impedance metering detection. The test is limited to 24 hours, and there are also some difficulties in the interpretation of on PPI studies, particularly because we know that PPI increased the number of weekly acidic episodes, but we have lack of data suggesting that the increased number of reflex events might suggest GERD or predict response to therapy or to medical or surgical therapy. Moreover, there is lack of normal values for on PPI studies, but we are working on that. There is an ongoing project for establishing normal values for impedance pH testing, also as compared to patients who undergo um, on PPI tests because of refractory GERD, and the results of this study, partial of these results, will be presented at the next DDW. I would like to stress that we focused on this limitation in the last 2 years, try to improve the ability of impedance pH monitoring to diagnose GERD, and we focused our attention mainly on reflux episode detection and on our capacity of identify the PSPW and the mean nocturnal baseline impedance. These latter two metrics are suggestive of impairment of mucosal integrity and the impairment of chemical clearance of the esophagus, and will be better discussed in the other part of the speech by my colleague, Professor Nicola de Bortoli. I would like to show 2 slides that highlight the process that we are going and we are working to better use the impedance pH testing. This consensus, the Wingate consensus, was published last year in 2020 on clinical gastroenterology pathology, and suggests the recommendation, the rules to better identify reflex episode and to better identify PSPW. We hope that the standardized definition of reflux episode and PSPW will be able to add future automated analysis using perhaps machine learning, artificial intelligence to improve and simplify the interpretation of pH impedance studies worldwide. Again, last year in 2020, we published the largest collection of normal values from impedance pH studies performed worldwide using 2 different systems, the Diversatech and the Laboris system. Data from these large studies say that the normal values we adopt in the past probably were a little bit overestimated, and in particular, the acid exposure time evidence found during the analysis was a little bit lower, as well as the number of reflux episodes calculated at the end of the studies was a little bit lower compared to the past. And this probably will help again to better understand the role of impedance pH in identifying GERD patient and in predicting the response to both medical and surgical therapy for patients who have an abnormal pH testing. Also, an important point highlighted by this study is that there are regional differences in terms of normal values and in terms of instruments that we use. So we conclude that we have to pay particular attention on the normal values of our region and according to the system that are adopted in each country. This is my last slide, and I'm looking forward to hearing what Nicola will tell us about the analysis of impedance pH tracing, about the utility of using the novel metrics, MMBI and PSPW, and the most recent data about the use of these metrics. Thanks for your attention.
Okay, dear Chairman, dear colleague, I would like to thank a lot Mark Fox and John Pandolfino for inviting me to share this presentation with Eduardo Savarino, that I thanks a lot, regarding advanced analysis of pH impedance study for GERD diagnosis. Okay, the indication and the most important indication to do esophageal pH impedance monitoring test are the presence of a typical symptom that persists despite PPI treatment, or to test a typical symptom that should be evaluated off treatment. And it's important even to detect abnormal acid exposure before anti-reflux procedure or surgery, or to diagnose supragastric belching that might be correlated with corrected by cognitive behavior treatment, as reported by Eduardo. Emerging indications are monitoring of reflux burden following anti-reflux procedure or after Ehlers-Danlos myotomy or POEM in patients with achalasia. Even high-resolution manometry should be compulsory in the diagnostic workup of patients with GERD. Firstly, for better localize upper border of LES before pH monitoring test. Then to exclude achalasia, to better define AGJ metrics and esophageal peristaltic performance. And it is very important to use high-resolution impedance and manometry to diagnose rumination syndrome. In 2017, Sabin Roman, an international working group for GERD diagnosis, updated the Porto consensus in a paper published in Neurogastroenterology and Motility. They report important indication both for patient and clinician. First, PPI should be discontinued at least 7 days before test of PPI evaluation. Patients should respect the overnight fast period and not to drink or eat for 6 hours before the test, and during the test, patients should maintain their regular activity. We even ask to our patient to exclude orange juice, soft drink, or carbonated beverage between meals, and patient should be instructed to correctly report their symptom and duration, and describe the time of meals and overnight rest. In the upgraded consensus, Porto consensus, some recommendations should be highlighted, even if with moderate, with very low level of evidence, but with a strong, are strongly recommended by the panel. The test should not be shorter than 16 hours. Automated analysis seems very adequate for acid reflux, but not for non-acid. That should be checked manually. And the manually analysis is suggested in particular during 2-minute time window before a symptom event. Low baseline impedance value makes interpretation quite difficult, and when the value of baseline impedance are lower than 500 ohms, they might suggest the presence of Barrett's esophagus, motor disorder, EOE, or fibrosis. Symptom index and symptom association probability should be considered both positive for symptom reflex correlation, and when these tests, SI and SIP, are both positive, acid exposure time is abnormal, we may conclude that GERD diagnosis and those parameters give us a high probability to have a nice response to PPI treatment. Now we have to talk about the two novel impedance parameter, baseline impedance and post-reflux swallow induced peristaltic wave. Baseline impedance was firstly described by Farey and co-worker because they performed acid perfusion experiment in healthy subjects and demonstrated that baseline impedance level drop and maintain low value after acid solution. This group showed a positive correlation between in vivo basal impedance and in vitro transepithelial resistance value. And the authors suggested that impedance-based measurement might be used to evaluate the impaired mucosal integrity in acid-induced heartburn. Similarly, the team of Amsterdam, Braden and co-workers showed that distal baseline impedance level in GERD patients were markedly lower than those observed in healthy volunteers. And inverse linear correlation among acid exposure time and baseline impedance was reported. This is the first study who evaluated mean nocturnal baseline impedance. So the calculation of baseline during nighttime, because a period in which baseline value seems more stable, because the esophageal mucosa collapse on the probe. In this study, we described a group of patients with impedance pH diagnosis of functional airborne, but with symptom relief during PPI. This group had a lower level of MNBI that completely overlapped with the patient with positive symptom reflex correlation, as well positive to PPI treatment. We concluded that mean nocturnal baseline impedance was able to identify patients with esophageal hypersensitivity, where SI and SIP fail to do it. In this study, Prakash Gyawali and Eduardo Savarino subgrouped patients according to the indication of Lyon consensus and evaluated MNBI in patients with inconclusive diagnosis of GERD. They concluded that when MNBI values are low, identify patients with pathologic and borderline acid exposure time who respond to anti-reflux therapy. MNBI analysis complements acid exposure time in defining esophageal reflux burden, and MNBI correlate with response of symptom to anti-reflux therapy. Baseline impedance value is very easy to be detected. We may select 10-minute window around 1 a.m., 2 a.m., and 3 a.m., and then have a mean value of this parameter. And we have only to pay attention to exclude the swallow period moment of reflux episode of pH drop that should be avoided. I think that now the most recent version of both software from different, so Diversatech, Medtronic, are now able to detect MNBI value directly in the report. The other interesting parameter is a post-reflux swallow-induced peristaltic wave, as well known as PSPW index. It represents the number of reflux events followed by a spontaneous swallow within 30 seconds, as reported in these two pictures, on total number of reflux events. In this study, we have just seen how it's easy to calculate PSPW index, that it requires a few minutes of manual analysis while we are checking the reflux event selected by the software. And the main finding that Marzio Frazzoni described in this paper in Neurogastroenterology and Motility in 2013 was that PSPW index is low in patients affected by GERD, and the values are very low in erosive GERD compared with non-erosive GERD. And there were no differences between healthy control and functional airborne patients. Even, moreover, Marzio Frazzoni described that probably PSPW index is not affected by the treatment. In this study, we evaluated firstly the both tests together, MNBI and PSPW index. We performed a prospective study with the consecutive patient with proton pump inhibitor responsive heartburn who underwent impedance pH. A ROC analysis showed that the area under the curve of PSPW index was significantly greater than that of the other impedance pH parameter. The value that maximized the sum of sensitivity and specificity was considered the best cutoff. So 2292 ohms for MNBI and 61% for PSPW index. And we concluded that analysis of impedance pH data by calculating PSPW index and MNBI can increase the accuracy of the diagnosis of patient with reflux disease compared to pH data alone. In this study performed, MNBI and PSPW index were evaluated in patient on treatment. Patients were subdivided into refractory reflux esophagitis, ill reflux esophagitis, non-erosive reflux disease patient, and functional airborne, accordingly to endoscopic and conventional impedance pH finding. The result of this study showed that both MNBI and PSPW index were lower in refractory esophagitis and progressively increased in ill esophagitis, in non-erosive reflux disease, and were normal in functional airborne. So at on-therapy impedance pH monitoring, PSPW index and MNBI efficiently distinguish PPI refractory NERD from functional airborne. And the PSPW index represent the independent predictor of a PPI refractory GERD. In this study, both tests, MNBI and PSPW index, were able to distinguish hypersensitive esophagus from functional airborne. And the performance of the two different adjunctive parameters when were combined in a ROC analysis, they showed a very strong area-ended curve, 0.96. And this value was greater than those of PSPW index and MNBI alone. In this paper, we evaluated off-therapy impedance pH tracing from PPI responsive and PPI refractory airborne. We considered demographic, endoscopic characteristic, conventional impedance pH variable, PSPW index, and MNBI, and all these data were assessed in a multivariate logistic regression to identify factors from independently are associated with PPI responsiveness. And the ROC analysis showed that acid exposure time, PSPW index, and MNBI were the only factor able to predict PPI responsiveness. But PSPW index and MNBI, both separately or combined, were superior to acid exposure time in predicting PPI responsiveness. In this study, performed in San Luis University and the Mayo Clinic of Colorado and Arizona, aimed to determine if a number of reflux episodes was associated with the therapeutic outcome in regurgitation predominant GERD. Patients were randomized in a 2-to-1 allocation for receiving a double dose of PPI or magnetic sphincter augmentation. Impedance pH analysis was performed pre and post-treatment, and the outcome was evaluated with the Foregut symptom questionnaire and the health-related quality of life. And the symptom score significantly improved after magnetic sphincter augmentation compared with the 2-time PPI. And both acid exposure time and reflux episode decline with therapy in patients who recorded and improved in symptom perception. And the ROC analysis showed that when the number of reflux episodes was lower than 35, an optimal symptom control was achieved. This is my last slide because I would like to present the future of pH impedance test. Because Prakash Gyawali and Eduardo Savarino evaluated the role of artificial intelligence in the pH impedance analysis. And during the development process, the two investigators evaluated manually and compared 2049 event of reflux with those who is identified by the software or artificial intelligence. and artificial intelligence was able to recognize 89% of these events. Artificial intelligence baseline impedance were compared with the mean nocturnal baseline impedance, and result showed that recumbent artificial intelligence baseline impedance, but not upright AIBI, strongly correlated with the MNBI. The author concluded that when upright to recumbent AIBI ratio was close to 1 or higher than 1, there was a very strong probability to have a positive outcome to treatment. Thank you very much for your attention.